Watch The Atheist Experience live Sundays at 4:30 p.m. Central. Visit tiny.cc/YTAXP and call into the show at 512-991-9242 or connect to the show online at tiny.cc/callaxp.
It's time to get sexy on Secular Sexuality.
Hello, and welcome to Secular Sexuality, the ACA show asking you to drop your pants and cough. I'm Christy Powell, and I am joined tonight by one of the hosts of the ACA's Truth Wanted, which means I am only a Kenneth Leonard away from completing my Infinity Gauntlet. Welcome to the show, physician and researcher, MD Aware.
Hey, thanks for having me. It's great to be here. And I'm really happy to be branching out into more ACA shows. I'm also collecting the Infinity Gauntlet of shows.
Right? Yeah. I have been doing this long enough. I've seen enough people come and go that I am just so proud to have you as my penultimate guest before I finally have completed all of the regular hosts. And really excited for the conversation that we're looking to get into tonight, because we're going to be looking at the way that gender is understood by doctors and the lawyers and the business executives, all in order to better understand gender diversity. So give us a call with your stories and questions. We're at 512-991-9242 or tiny.cc/callsex, because the show is coming right now. All right, well, let's do it. MD, super excited to have you here. Really glad to be rounding out the host schedule, but more importantly, to actually get a chance to appear on air with you and get to know you a little bit, pick your brain. I think the best way to truly understand another human being is to find out exactly what turns them on. So what's got you revved up this week?
Well, so recently, a couple of my friends, my wife and I, we went and saw this French movie called Titane. Have you seen it?
Yeah, absolutely. That actually is what was turning me on a couple of months ago. I love this messy, dirty movie. Tell the audience about it.
Okay, so let's see. So there's a woman who's so as a child, you start out to see this child, and she gets in a car accident, whacks her head, and needs a titanium plate put in.
As one does.
As one does, exactly. Flash forward, she's now a go-go dancer at a, I don't know, some fancy car lot, car show sort of thing. And she gets harassed by some random dude, and starts coming onto her, and sort of in self-defense, it seems, she stabs him through the air with like a chopstick that she keeps in her hair, right? And turns out she does this a lot, and she's actually like a secret serial killer. But right after she does that, she goes and she has sex with like a Cadillac or something. I don't know what the like physics of that whole interaction are, but that's definitely what happens.
It's gripping cinema no matter how you slice it. I have to say, like, on paper it all seems very strange, and on film it actually is incredibly strange. But it's a good time, right?
Oh yeah, it's great. And like, let's see, she then gets pregnant with a car baby, and later also has sex with a fire truck, I think.
So if you are uncomfortable with body horror, if you have trauma specific to like ace bandage binding, or to pregnancy, or some of these other things, you might want to be a little bit mindful, maybe read up before you jump in. But if you are looking to, I don't know, have a few drinks and throw yourself to the winds of French cinema, this is a good time.
Yeah, totally.
Well, I love that you're here peddling a bunch of filth. Never mind the fact that I recommended that movie a few months ago, because now I get to sound next to this doctor very like sophisticated when I recommend The Principles of Pleasure, which is a docuseries on Netflix. I'll admit that I'm only a couple of episodes in, but I'm really excited about it. Emily Nagoski and a handful of other folks that I really, really admire have put together this pretty remarkable docuseries where they talk about primarily female sexuality and kind of the fact that nobody bothers to talk about female sexuality. The first episode in particular really highlights the fact that for so much of sex research, we've basically assumed like men are the default and women are broken men. And this series helps to sort of explore like how we got there and why we make those assumptions and how they maybe aren't the most helpful beliefs that we could possibly have. So it's definitely a good time.
Yeah, I mean, I think I've heard about it. I was saying before the show, I think some of my colleagues in like women's health urology have gotten a little bit irritated, but it may be a different Netflix series about sex. There are a couple on there.
Yeah, so I'll actually be super excited to revisit this conversation. I hope that you will take a look and let me know, because my early impressions were that it started off a little slow, but had some really, really interesting points to make. And as I was watching it with my partner, I was really curious how she was going to react to it, because I'm kind of steeped in this shit. Like I, have read that sort of like introductory to human sexuality book a handful of different times from a number of different authors. And I was really curious how she would experience it, not necessarily for the first time, but with maybe a little bit fresher eyes. And it was the type of thing that even though I was watching it and she was like cooking and cleaning and kind of hanging out in the background, that we ended up talking about it the next day, and she was bringing it up over and over again. And just the impression that it made on her was pretty extreme. So I guess I just want to really stress that human sexuality, particularly female sexuality, is something that our society has done just a garbage job of explaining and exploring and creating space for conversation about. And accurate or inaccurate, if this particular piece of art starts to create some conversation, I'm excited for it. Definitely, I don't want to contribute to like the spread of misinformation, but this felt like something worth taking a look at.
Yeah, totally. And they say like all press is good press, right? So if it gets a conversation going, at least there's an opportunity there.
Yeah, fair to say. So with that in mind, there was a brief conversation that you had on an episode of Truth Wanted recently that kind of made me sit up and take note, and brought a lot of curiosity to me, got us talking about some different ways of viewing, I suppose, gender in general and kind of human bodies and what we should or should not, or whether should is even the appropriate term for the way that we look at these sorts of things. So let's take a look at that clip and maybe jump off from there.
But there's a notion that has existed for years that people can feel that their gender is not consistent with their anatomy or their outward appearance. Do you agree that that exists, that there is such a thing as a dysphoria, people feeling like what they feel they are inside is not compatible with what they are on the outside?
I believe people can feel that way, but I don't believe that just because people.
Okay, stop. Okay, so you believe that people feel that way. Now, from a medical perspective, that's a problem, right? Because people are feeling bad, and it's our job as a society, and more tightly from my perspective as a healthcare provider, to try to fix that. So what's the best solution? The best solution, based on the science, and student Dr. Ben, who was on the clip show last week, said this very well. The best thing that we know how to do to help these people manage their gender dysphoria is to support their transition. you know, even if you wanted to call it a mental illness, it doesn't matter because it's all about treatment and distress. So if you want to say that, like, whatever you want to label it, the appropriate thing to do is to support people in their transition. Like, period. Otherwise, you're not doing them any favors. And frankly, all this you don't believe in the existence of someone being transgender is just labels again. So if you say that you agree that people can have gender dysphoria, which is causing them distress, then they should be entitled, should they not, to seek care in the same way that someone having a heart attack is entitled to seek care for their heart attack, right?
You cannot compare a heart attack with mental illness. One is legal.
Well, why? Oh, hang on. Is mental illness? Let's put this gender thing aside for a second. Is mental illness somehow different from illness otherwise?
Mental illness. Look, gender is not gender.
No.
Gender is not.
Answer my question. Is depression different from Crohn's disease? Fundamentally, as a disease process.
I don't see what it has to do with it.
What it has to do with it is mental illness is illness, okay? There is no difference between mental illness and illness, okay? Anyone who has an illness, be it mental or otherwise, has the right to seek care for it and should be offered the appropriate care for it. And when it comes to someone who's experiencing what we understand as being gender dysphoria, they have the right to seek the appropriate care, which we know from all of our scientific studies is a support through a transition, which includes things like hormone therapy and surgery, gender affirming surgery. So where's the problem?
You cannot compare a heart attack with gender dysphoria. It's in your
Why?
head.
Listening.
Okay,
what's the difference?
If someone thinks that they're a dog, does that mean if someone feels strongly that they're a dog, does that mean we should let them behave like dogs? If a child thinks they're a bird,
if we have science to back up that is the best way to approach their specific problem, then yes. If you want to be humanitarian about things.
So you're telling me it's okay to let a child act like a bird and then jump off the roof, try to fly, and jump.
We have evidence that it's the best thing for that person, then yes.
All right. Well, there's a lot to unpack there. I know that we trimmed that clip down a little bit, and James ended up hanging up before you were able to like really walk in through these things. I guess I want to start by just acknowledging the fact that you were pretty like quick on your feet in tackling some very kind of drunken boxing style of dialogue, and then also note Shannon's very obvious desire to like pull back and not attack. So congratulations on the way y'all managed that call. But after the fact, is there anything that you would want to kind of add or maybe explain about your point of view here?
Yeah, so I think a lot of, obviously things are a little bit different when we have a call-in show and someone's calling and we don't really know where they're coming from, what their background is and stuff, right? So, sorry. So we obviously need to take different approaches with different people. And so I think when someone calls in and they are very recalcitrant to modern understandings of like transgenderism, then you have to take a little bit more of a practical approach. That's been my experience anyways. And so that's the approach that I've used in the past, is very focused on, problem and solution. And I think it's the easiest one potentially to argue because we have good medical evidence to support it, right? And so if you can get someone to acknowledge that there's a person suffering from gender dysphoria and the way to alleviate that dysphoria is with a particular treatment, then they then have to justify why we shouldn't be applying that treatment. So that's been my general approach. And obviously, it would be different if people were calling in with a different attitude and a different perspective and different understanding.
Sure. And I definitely hear that. And I am honestly really excited to kind of tease some of this apart because while I don't want to oversimplify things, what we're really looking at here is the question of whether or not being transgender inherently requires a level of distress, or whether that that issue or that concern of feeling like you are in the quote wrong body is like a necessary ingredient. And I think that that's a really interesting and important conversation for us as a society to be wrestling with. I don't even really mean to say answering, because even though we're going to be exploring some different models and some different ways of looking at it, I don't think it's at all fair to suggest that you or I could have a quote answer to that question. But there's a lot of really meaningful things to explore. So as we're getting into this, I guess I want to just acknowledge that we're going to be exploring some maybe philosophical themes, which is sort of a brash way for me to say that we're going to be talking about transgenderism in sort of an abstract way. And I can appreciate why that would be uncomfortable or triggering for a large percentage of our audience. So if you're watching this and this conversation feels uncomfortable or unnecessary for your mental health, thank you for being here. Thank you for being a part of our community and for watching the show. You are more than welcome to log off and do your own thing. We certainly, as two cis men, want to handle this conversation as kindly and as compassionately as possible. But if you feel like we've gotten it wrong, let us know. Please reach out. Please call in. Please do whatever you need to do in order to take care of yourself and in order to maybe have your point of view heard. But we're going to dive into it a little bit.
Yeah, I'm excited. I hope to get some new perspectives and learn as well tonight.
Yeah. Well, so that in mind, let's, I guess, kind of summarize the conversation so far, right?
Sure.
If we're looking at like ICD from the World Health Organization or the DSM from the American Psychological Association, both of those manuals have dramatically changed their understanding of trans bodies and trans needs in each of the last 3 editions. Can you kind of summarize for us a little bit the way that the medical establishment has evolved in their thinking over the past 50 years or so? I know that that's a big task, but if you can set the table for us a little bit, we can dive in from there.
Sure. So, I mean, I think the biggest change that I would point out is that when we moved from the DSM-4 TR to the DSM-5, the major change was that we moved from the diagnosis being gender identity disorder to gender dysphoria, which I think fundamentally represents a shift away from the pathologizing of the gender identity and towards a focus on the patient's experience and the person's experience. And I think, you know, the DSM has a sordid history of sort of pathologizing things that become problematic, right? Like, I don't remember when it was phased out, but at one point homosexuality was classified as a mental illness according to the DSM, right?
Sure. Yeah, that was in not the first 2, but in the 3rd edition, and then not in the 4th.
Right.
But worth noting that for I think some 10 years there in the 70s, that was a classifiable mental illness, quote unquote.
And so obviously the DSM is not gospel,
Sure.
so to speak, and it's evolving, and it's, you know, made by people and a large group of people who are experts in their field, but people all the same and can make mistakes. But I think that the change represents a shift in the way the medical establishment is understanding things, away from the focus on, you know, what a disease is on a fundamental note and a focus towards how it affects patients. And I don't know, maybe we can get into it later after we've gone through some of the other stuff, but I think this reflects a change in the way that medicine overall is discussing all pathology and not just gender-related pathology. So I'd be interested to talk about that as well.
Yeah, absolutely. I think a lot of this conversation, at least for me, kind of hinges on the way that the neurodiversity movement, in particular, has addressed the quote unquote question of autism. I don't want to overly simplify the neurodiversity model, and I also don't want to overly conflate it with some of the conversations that we're having tonight. But very briefly, to maybe set the table for folks, at least in the way I think about these issues, when I think about being transgender, I think about it in terms of a natural human diversity. The idea that human beings are going to be genetically and environmentally and in the way that we express ourselves, like phenotypically, going to be just naturally diverse in a number of ways, and that we're not going to fit into discrete boxes in a large number of occasions. The neurodiversity movement in particular has worked to say being ADHD or having autism or being autistic, depending on your framework and some of the language that we use, that these things are not illnesses. They're just simply different ways of being. And any disease aspect that we might ascribe to something like having struggles with reading or having struggles with sensory processing or some of these things are not so much diseases in and of themselves as they are being left-handed in a right-handed world or trying to exist in a cultural framework that was built towards a majority that doesn't necessarily properly capture all of the diversity and all of the intricacies of being a human being. That's something similar to the model that I tend to use when I think about being transgender. But of course, all of this is made up, right? All of this is just a conceptual framework created by humans to try and describe our world, and it's imperfect and it doesn't capture everybody. And so looking at some of those models and trying to understand how we can maybe better explore and know what it means to be a human is sort of what we're here to do tonight. So I'm hoping that you can, in brief, maybe try to summarize for us what we might call the medical model, or perhaps sometimes people use the term distress model or pathology model. Those three things might even be separate, but for the purposes of our conversation, how can you maybe define some of those ideas for us?
Sure. So I'll start by adding the caveat that I'm not a psychiatrist. I'm a medical doctor, and I've done research in cancer. So this is not my area of subspecialization. But I've done, obviously rotations in psychiatry and had to treat patients from a surgical perspective who were trans. And so I have that sort of experience, and I think it perhaps represents how doctors who are coming out of training today, your average doctor who's not a trans care specialist, would understand things. And I actually think it's not too different from sort of the neurodiversity model that you were describing a few moments ago. The old school is very focused on the pathology. And so it's often a binary. It's a yes or no. Do you have these qualities? Do you portray these, in a mental health diagnosis, there will be a bunch of hallmarks of a particular mental illness.
Symptoms, right?
Symptoms,
if we're being
essentially
frank, yeah.
Symptoms. Yeah. And, the old school would say, if you have those symptoms, then you meet this, this criteria, this diagnosis, and you're into that box. The modern understanding, and you'll see in the DSM-5, and I think even in the DSM-4 TR it was, there's, a bunch of criteria, and they're listed like A1, and the symptoms are under A, and it's 1, 2, 3, 4, 5, 6. Then if you go to B, it says, and it's causing interference with your daily function, affecting your life, causing you distress, that sort of thing. And so I think that's really representative of how modern doctors approach all disease and not just mental health. Is it a clinical problem in that it's affecting your function, it's affecting my patient's well-being, and as a result, we need to do something about it to help them? Or is it subclinical, in which case we don't need to do anything? They don't need a diagnosis, right? They're just a person who has a particular, as you said, they're maybe not falling into the majority norm of your standard curve for whatever characteristic you're talking about, but it's not affecting them, so we don't have to do anything about it.
That
so
term,
we purposely don't pathologize those people.
Exactly. Yeah, that term subclinical, I think, is a sticky wicket. It is complicated in a lot of ways. But without wanting to get like too deep into it, I guess I just want to say that I will watch TV and they will sort of reference the DSM, and they'll sometimes call it like the Bible of being a therapist and these different things. And the truth is, as a counselor, I'm not maybe representative of everybody, but I use the DSM 95% of the time to help sort of show somebody that they don't have the condition that they just diagnosed themselves with from WebMD or something along those lines. Like, I'm not using the DSM in that way because if we're being honest, the DSM, at least in my opinion or in my experience, is mostly about proving that your problem is bad enough that an insurance company should be obligated to help you pay for treatment regarding it. That's certainly not the only purpose of the DSM, but this is something that is largely created so that insurance companies have a frame of reference, and it's not oriented towards like wellness or what we might call positive psychology so much as it is like highlighting areas of distress, highlighting things that are going wrong, because for a insurance company to pay for your problem, you need to demonstrate that it's causing an issue. Is that a fair framework?
I mean, it's a little bit different from me because I work in practice in Canada, where we don't have to deal with difficult insurance companies per se. We have the government is our insurer. And so they have, a list of criteria or a list of conditions that they'll cover. And so certainly the DSM is used by them to decide what constitutes a problem that they then have to cover through their insurance. But I don't think it started that way. And obviously it's the American Psychological Association.
Sure.
So it's fundamentally based in the US, but I think it started fundamentally as a way for doctors and psychologists to try to organize people to figure out how to study mental illness and how to treat it. Because that is, I think, the basis for a lot of medicine is, it's all patterns. And as you say, there is a diversity even within, I'll use an example of like appendicitis, which is something I treat a lot of, right? It's inflammation of the appendix, and people present differently. They can look totally different. A lot of them look the same. Again, we've got like a general pattern that comes up very frequently, but people
that term
deviate
diagnostic and statistical is meaningful. Like, we tend to just summarize DSM, and those words start to lose their meaning. But it's worth remembering that we are talking about how people stereotypically or are statistically likely to present.
Right, and those classifications are useful mostly for research purposes and to a certain degree for treatment purposes historically. Because
there's a predictive value in that sense.
Right, exactly. And I think that that's probably how the DSM started and was intentioned, right? They wanted to put people into boxes so they could say, well, what works for this condition? We can't try every remedy under the sun for each person. So we try to group people together so we have enough statistical power and can draw some real scientific conclusions about what works best for them.
So it's certainly not a perfect model, and I think that people working in the field largely recognize that, even if we don't always remember it on a day-to-day basis. But from the outside, I think it's really important, MD, for folks like you and I to try and communicate to the people who are watching shows like this that when you work in the field, these labels, these diagnostic labels, these books are imperfect, and we don't expect them to be quote unquote right so much as just a guideline or a way of understanding things. And so to that end, I want to, I guess, just very briefly and maybe even like criminally under explain a couple of other models when we're talking particularly about gender and about transgender healthcare. The first is what is known as the interactional model, which I want to really recognize for the audience I am under summarizing, and that you could probably do well to explore or read about for yourself. But the interactional model of gender is, roughly speaking, the belief system that gender is a form of expression, and therefore it relies on sort of our looking glass self. It relies on the way that people interact with our gender. That if you were living on a deserted island by yourself, you might not even, quote, have a gender, except that even on that island, you're going to be there also experiencing yourself and experiencing your gender. So all gender is sort of defined through the idea of expression, how you explain yourself to other people, and then how they react to it. So in that lens, or from that point of view, your gender couldn't possibly have a distress component except for the ways in which your body or your experience of yourself doesn't line up with the way that you feel that it should, or in the ways that other people experience you, you don't code correctly from a certain point of view. If you express to somebody, I am a man, and they don't see you as a man, that would be transgender or transgender distress or gender dysphoria, depending on exactly how you look at it. And then next to that, I might put the informed consent model, which is basically an idea around bodily autonomy. That when we're talking about things like hormone replacement therapies, when we're talking about gender confirmation surgeries and some of these other ideas, the informed consent model might express, hey, it doesn't matter if I am a man or a woman or whatever else. It doesn't matter if you think that I am a man or a woman or an NB person or anything else. I have bodily autonomy and the right to make my own healthcare decisions. Ergo, vis-a-vis concordantly, I have the right to take testosterone. I have the right to be prescribed estrogen, or I have the right to change or manage my body and the way that it expresses itself on my own. With all of that being said, all of these different models, all these different frameworks that we're just kind of like throwing out into the ether, I'm curious, MD, what you, in like very human terms, how you as a cisgender physician understand the medical needs of trans folks.
Yeah, so I think that that's a really good question, and I think it draws the appropriate distinction between, you know, the interactional model that you were talking about and sort of the medical model, we can call it. Physicians are predominantly concerned about problems and solutions. We're basically like human body mechanics, and I say this as like a surgeon, so I especially consider myself kind of like a plumber of the human body. Mm-hmm. And so I think that, you know, the interactional model I actually agree with, and to a certain degree I also agree with the informed consent model. I think there are some issues with it that we can get into, but like, so with the interactional model, correct me if I'm wrong, you would say that like if someone lives in isolation, they don't necessarily have a gender per se in the way that we would understand it. And in the way that we understand it currently, right?
Yes and no. This is maybe a complex idea and maybe more philosophical than medical and not super falsifiable. But for myself as a therapist, I operate in a lot of framework that sort of depends on the looking glass self, or the way that we experience ourselves, which is to say, I guess to simplify, if you are angry at your mom, for instance, it would be useful for you to be able to hear an apology from her, for you to like come to terms with that, for you to express why you're angry, and for her to apologize, and for you to give forgiveness. Like that would be a beautiful thing. But oftentimes when I work with a client on that type of anger, that's not an option. That's not an opportunity. Perhaps mom is just not willing to engage in that conversation. Perhaps mom is passed on, or in some other way unavailable. And so we can still do things in a therapeutic sense that would be like, for instance, writing a letter to your mother who has died, or having a conversation with an empty chair. And we can rely on those types of like mental models of your mother in order to explore those feelings. So when I think about gender, I think very much about the way that we have sort of control over our own fantasies, and we can sort of imagine these experiences. So in that sense, I really do believe that somebody on a deserted island by themselves still, quote, has a gender, even if it's going to be defined very differently. And that's going to be especially true of somebody in this, thought experiment who never actually met anybody else. If you had a baby raised in isolation, their concept or their gender, I suppose, in that idea would be non-existent.
Right. If you asked them what their gender was, they wouldn't understand the question, essentially, right?
Right. Which, again, in this thought experiment, somehow they've learned English by themselves in isolation. But nevertheless, as long as we're playing with it.
Yeah. So, I mean, I think that that's not at all at odds with the medical model. I think that physicians in the medical model is predominantly concerned only with those people who require our care. And that's like really, to put it bluntly, that's what we care about. And obviously trans care from a medical perspective still goes far beyond, just providing hormones and surgery. So if I were a family physician, I would have to care about the mental health aspect of it that often accompanies clinical transgender patients, the discrimination they would face and the marginalization they would face, and how I could potentially help with that problem. But again, these are all problem-oriented things, because ideally, I want to never see my patients again because they don't need me, because I'm just a problem solver for them. I'm a mechanic. They come to me with a problem and I fix it, and then I don't want to see them again, because if I do, it means that I haven't done my job right. And so I think, the interactional model and the medical model are not necessarily at odds. It's just that the interactional model, I think, is much more broad and looks at all degrees of the trans spectrum and the gender spectrum, in terms of both the severity of any potential dysphoria or potential distress, whereas the medical model focuses only on those individuals who are distressed in some capacity.
Yeah, and it's probably worth pointing out that none of these models is, quote, correct or incorrect, but they are a different way of viewing things. I might think about it in terms of like bifocals versus telescopes versus microscopes, because as we discuss being transgender in 2022 North America, find me a trans person who has not experienced meaningful distress because of bigotry, because of like societal concerns,
right?
And I'll be blown away. So in our modern conceptualization, we almost always, or perhaps even exclusively, think about being trans in a almost pathological kind of lens. We assume that there's a level of distress, and perhaps that wouldn't be the case, or perhaps that doesn't need to be the case in a more egalitarian or perhaps utopian society
Sure.
I've never lived there. So
Right.
my
Yeah.
concept of that is all fantasy at this point.
Right. And I agree. And I think that that's a good point because I agree that I think a lot of the problems, like you raised with the neurodiversity movement, also applies to the gender spectrum as well, where a lot of the distress comes from the interactions with society. And, you know, you can approach, again, as a problem solver, you can approach that distress in two ways. You can say, well, we need to help the person fit with the society, or we can say we need to make the society fit the people. And I think that one of those is much easier to do than the other, which is the one that we do, right? So we're practical in our approach to it, because I agree, ideally, we could just create, an egalitarian ideological society where people are accepted regardless of how they identify in every way. And they don't face any marginalization or barriers. But I think from a practical perspective, we can both acknowledge that we don't live in that world, and creating that world is certainly not going to happen probably within our lifetimes. And so I think it's important to have something like the medical model to enable us to help people who need it now, people who are suffering now. And that's, I think, really what the focus is focusing on the person, you know, in the medical context, the patient in front of you, and what they're going through and how you can help them.
Well, and I don't want to be unfair about this question, but I'm just overwhelmed with curiosity. So I have to ask you about your thoughts on the informed consent model. Because on the one hand, I am somebody who wants to respect and believe in other people's bodily autonomy. On the other hand, and forgive me if this is like a shitty example, but I cannot get behind a model that would say, for instance, that it is okay for a bunch of QAnon supporters to have access to ivermectin. Any sort of model that allows people to make decisions about their own body in ways that are perhaps reckless or that are not maybe informed to the degree that I would like them to be. I don't know if that could be seen as authoritarian, but I'm really curious as a physician what your perspective on that idea is.
Yeah, so the whole notion of like bodily autonomy has come a long way in the past probably 50 years. So my grandfather was an OB-GYN, and back when he was practicing, they practiced what's called a paternalistic model of medicine, which you may have heard that term before. But essentially it means the doctor is the keeper of the resources and the arbiter of diagnoses and treatments. And if the doctor says you take this, then you take that medication. And if the doctor says you don't get to have this operation, then you don't get to have the operation, and there's no discussion. Again, being like new school, we are very dialogue focused, and we practice what's called patient-centered care, or at least we try to. And that gives a lot more autonomy to the patient. So a lot of the discussions I have with patients, instead of me saying, this is the treatment, I say, well, here are the options. Here's what we know about the options. Here's the one that I think works the best in my medical opinion. And that's the one that I would recommend, but it's up to you. And, you know, these discussions are often grounded in a conversation about the patient's values. So I'll give you an example. One of the things that I talk about a lot is end of life. I take care of a lot of sick patients in the intensive care unit. And so there are discussions that we have, usually not with the patients, but with their families, about whether or not we should withdraw life-sustaining treatment. And how those conversations always start is, tell me about your loved one. Tell me about your father, your mother, your daughter, whoever. What would they like? What are their values? What do you think they would want for themselves if they were, you know, able to make this decision? And we get to know them. And based on that knowledge, based on an assessment of what the patient's values are, then we will lay out the options and recommend a treatment. And so this is the new autonomy that we try to give to patients. And although we try to give autonomy to patients, it has limits, which I think is where you're starting to come from with your objections to the informed consent model, which I agree with.
So it is somewhat blended. Like you can't do
Yeah.
exclusively one or the other, at least in your
Right.
opinion. Yeah.
Well, I think you can't in my opinion, and I don't think you can practically either, right? And I also don't think it's a good idea to do it. So another classic example is parents will come in with their children who have an ear infection, and you assess it, and it looks like a viral ear infection, and they will demand antibiotics.
Mm.
And there's a lot of scientific reasons why it's not a good idea to give out antibiotics like candy. The most important one, so number one, it won't work to cure a viral infection, right?
Right.
That goes back to your ivermectin and COVID example, right? Ivermectin as like an antiparasitic will not help COVID, will not treat COVID, and antibiotics won't treat a viral infection. But they'll also contribute to the development of superbacteria and things like this, right?
Right.
So obviously, you can't have 100% autonomy. You can't allow that. And I mean, the most distressing examples and the most extreme examples are, again, patients I see who come in and they potentially, they've done some sort of self-surgery or something like that to themselves. And it's usually for an underlying reason of mental health. There's this notion of, give me a second to look it up here. I lost it. There's a particular mental illness where a person can, as part of their identity, they believe that they're, for instance, disabled when their body is not disabled.
Sure.
And so they will seek to align their body with their internal identity, right? And so sometimes that means they want you to amputate a limb when it's not medically called for, or perform a spinal transection to make them a quadriplegic or a paraplegic or something like that. And in those cases, we don't facilitate that sort of identity affirming care, as you might say, because there's no good evidence that that's going to help their problem. And in some cases, there's evidence that it is detrimental, that their problem persists after this happens, in patients who don't necessarily get it done by a medical professional, but do it themselves and then come afterwards to the hospital to seek, post trauma care or post operation care. And so I think that there's problems from that perspective with just enabling anyone to do whatever they want. And there's also resource problems, right? We simply can't afford, as people who live in a universe of finite resources, we don't have the resources to give everyone all of the care that they want. And so we have to base our decisions on allocation of medical care, for example, based on the resources that we have and how best to use them.
Yeah. So ultimately, it isn't just a like community health problem, like in the superbug antibiotic for antivirals example, but there's also something that I guess as an outsider I'll refer to as like a Hippocratic oath problem of causing distress or allowing somebody to come to harm because of your medical intervention, even if it is at their request. Yeah.
Right, exactly. And I mean, that's the big, I think one of the big debates that people have currently. Some of the, again, older school surgeons who don't necessarily believe the research on gender affirming surgery will say, I'm not going to do that surgery. And then you get into this question of autonomy, right? Whose autonomy trumps whose? Does the patient have the right to force the surgeon to perform a procedure that the surgeon doesn't want to do? Does the patient have the right to force a medical professional to prescribe medication that they don't want to prescribe? So there are a lot of predominantly Christian physicians who refuse to provide like birth control or abortion care. And the way that we've gotten around it here in Canada is that physicians have a duty to refer. So they don't have to provide the care, but they have to refer the patient to someone who will provide the care. Of course, the question then becomes, what do you do if no physician is going to provide the care that you want?
Yeah, well, I'll tell you what, I was actually briefly expelled during my graduate studies because of my attendance at a Christian university and my sort of aggressive stance on the appropriateness of counselors referring people out because of their orientation or their identity as homosexual. So
Mm.
there is a lot to play with here. I'm really appreciating this conversation. But before we get any deeper into it, let's take a quick moment and see what's been going on around the rest of the ACA.
Good government and good legislation for y'all.
Here's hoping.
Yeah, and then this sex show can get back to hopping on the good foot and doing the bad thing. Like, we would like to not be talking about politics on it's really getting in the way of our conversation.
You know, we're just a fact of the universe, and some people that makes them uncomfortable. For the rest of us, we've learned to live with it and figure out what to do next. And sometimes that includes going on call-in shows. But other times it means loving your family and doing things that make you happy and just being a human.
They need to appeal to people in these toxic churches and bring them in and show them that there's a kinder, gentler way to be a Christian.
I gotta say, Kelly, I might go back to church if there were pool tables or air hockey, but
if we're just going to use a methodology of common sense and not give a shit about what we believe in the world, then my common sense is just better than yours. Why? Because it's common sense. Do I need to actually provide independent justification? No, because I'll just side with my common sense because I'm irresponsible and don't care about knowing the truth.
If your view is, I have no good reason to believe this, I can't demonstrate to anybody, I just believe, cool, go get yourself a friend. I'm not your friend. I can be friendly and I can be a prick.
Well, I am having a great time diving into all of these particulars and trying to understand the world through all of these different lenses. But ultimately, I guess I'm curious what you believe your model does really well, or what it is about the way that you view some of these issues that you might recommend to others.
Sure. So I think what the medical model does really well is sort of what I've been alluding to, which is solving problems. And what that really comes down to is, I think, taking care of the wellness of the individual. And so when we talk about all of this trans care in the framework of the medical model, the goal is always patient-centered. So the goal is not primarily to affirm the gender of the to affirm the gender identity. It's to do what's best for the individual that's in front of us, right? And so that's sort of the guiding principle. And I think that that corresponds with what I think is the basis of secular morality. You know, trying to improve the lives of humans, reduce suffering. And I think that that's the best thing. And I think that, you know, in contrast to some other models, again, we're going to be a little bit more humanistic. You can correct me, Christy. My sort of perception is that some of these other models might put the identity at the center and the sort of veneration of the identity or the support of the identity itself at the center of the model, rather than the individuals who might you know, claim to have that identity themselves.
Yeah,
what do you think
I'm
about
sorry.
that?
Can you say that again? Walk me through what you're asking.
Sure. So I guess my question, because I might have this wrong, my question is that do some of these other models, do they put the individual, so in this case the trans individual, at the center of them, or do they put the identity itself at the center? Like, is it more important to these models to affirm, you know, transgender identities, or is it more important to support the individual people?
Yeah, I think that's a great question. As a therapist, I suppose I tend to approach things from a very individualistic point of view. I have gotten a lot of flack for it before, but I often will say on this show that if there are 7.75 billion people on the planet, then we've got 7.75 billion different genders, that everybody is unique in that way. But for practical reasons, we tend to group people together. And I don't see an issue with that. Just existentially, it makes sense to me that all of these models that we're using, all of these boxes that we are creating, are just intellectual framework and are totally made up and essentially, if not completely arbitrary, at least somewhat based on our imagination more than anything else.
Right.
There is real value in taking a more like sociological standpoint, but I hope that that is always from a descriptive rather than like a prescriptive sense, that we never tell people, well, you are this gender, therefore you must act or behave or look in this way. And instead, people will come to us and say, here is a adjective, here is a word, here is, if we really want to break it down, here is a sound or a vibration frequency that you can make with your vocal folds in order to describe me.
Yeah, I mean, I again largely agree. I think, to your point, the way that society has understood gender has been mostly a practical, a pragmatic, a convenience framework, right? And when you get away from that sort of framework, you lose, and like, as you were describing at the end there, a certain frequency or a certain vibration with your vocal folds, you start to wonder, well, what does that mean? And people, I think, in public don't know how to understand what that means, right? And so, yeah, I agree. Of course, I think that there's a huge diversity of gender identity, and I think what I mentioned on The Truth Wanted is I only really fundamentally care if it's causing you distress.
In order for something to be a problem, it has to cause an issue.
Right, exactly. And again, approaching it from the medical perspective, you can call yourself whatever gender you want. It doesn't really make a difference to me. As long as, like, it only matters to me to the point that it affects your wellness, your health, and the care that I have to provide. So, like, I can give you an example. I once treated a trans man who came in with appendicitis, and the only reason that I needed to know that they were trans is because I needed to know that they had ovaries, because appendicitis can affect the ovaries. And I had to say, when I was having my discussion, now there's a possibility that your ovary might be involved, and we might need to remove the ovary to make sure we get all of the infection out. And that's about it, right? Like, I did the rest of their
There's
gender
not a
identity.
moral component to any of these things, just a very practical need to understand, are we working with a testy, or what are we working with?
Yeah, exactly. And honestly, that's about as far as it goes from a medical standpoint and from the medical model. Like you said, if it's not causing a problem, then it's not an issue.
So ultimately, then, is it fair for us to boil this entire conversation down to a question around whether gender non-concordance is a pathology, or whether distress is necessary for transgenderism to exist, or how should we be thinking about these things?
Yeah, so this, I think, is a good opportunity for me to bring up what I was alluding to at the beginning, which is how I think the understanding of medicine and disease has evolved. And I hope this isn't too heady or too off topic, but I think that we have generally begun to understand that basically, like, almost every medical condition, every medical illness that you would classically think about exists on a spectrum. And again, we have historically seen only the most severe and distressing forms of that because they're the ones that show up. There's a lot of cases, say, for instance, of like a common cold that people don't even know that they have, and they transmit right? And it goes around in a population, but no one ever knows about it because it doesn't cause any problems. So does that exist as a disease? Well, we would probably say no, because it's not causing distress. It's not causing dis-ease. But if that same process, that same, biological process, that same pathology persists and gets worse to a certain degree, then we would call it an illness or a disease because it's causing dis-ease. And so in the same way, I think that this notion of like gender dysphoria, transgenderism, as we've been calling it, exists on a spectrum. And I think that a lot of people are, this underlying, whatever component it is, mental, psychosocial interaction, exists to different degrees in the population. And the most distressing ones present as gender dysphoria. And then we have to treat them medically. But there's a whole swath of people who have transgenderism to some degree that that we never see. And there's, it's not like that underlying process isn't ongoing. So I would say that it still exists without being a disease. It's just that when it crosses a certain boundary that it starts to cause distress, that's when it becomes a disease.
Sure. And that's when the medical establishment steps in. But I think it raises sort of a interesting thought experiment as to whether or not in some hypothetical utopian society, people would experience being transgender at all, or if folks that we currently describe as transgender and will often, not prescriptively or not in a like mandatory fashion, but folks that we currently offer things like hormone replacement therapies and things like gender confirmation surgeries, in some sort of utopian society, would those be necessary? Would it be possible for somebody to be born with testes and a penis and identify as a woman without any type of medical intervention? And is it right for us to maybe see that as a need?
Yeah, it's a good question. So I was talking with one of my friends who is a psychiatrist and deals with a lot of trans patients about this. And his suspicion is that there are people who are trans who don't feel distress about it. They have that identity, and it is the things that they feel they need to do are expressed in ways that don't require medical intervention. And like some of the things that he described are like transvestitism is potentially an expression of an underlying, inclination towards towards the opposite gender role, without being a full, sort of a full-blown transgender, or these people who identify as being gender fluid. Obviously they exist somewhere in between, or they go back and forth, and that is often subclinical as well, right? And so I think, again, these people I think exist, and your question is interesting. What would happen to these people in an ideal society? I would hope that ideally the societal pressure to conform would be gone, and therefore they would not feel any need to, or any distress because they're not conforming with any gender norms. But I think really what that means is the ultimate like abolishment of gender in the way that we understand it socially now, right? What you would really, I think, then be looking at is the society where the question of gender sort of doesn't mean anything, right? It's like everyone is just who they are, and we'd almost see gender in the same way that you would see someone's name. It's like, well, yeah, I'm MD and you're Christy, and I don't understand what more you could want.
Why we have to box it up?
Yeah.
Which, if you live in a society which the vast majority, what I mean to say is the vast majority of human history, most human beings have known what, somewhere between like 25 and maybe 100 other human beings.
Right.
And so when you don't have to conceptualize, thousands of like random interactions with strangers, hundreds of celebrities, and dozens upon dozens of acquaintances and friends and everything else, perhaps it would be a lot easier and you wouldn't necessarily need these broad categories. I want to be really careful when we talk about evolutionary psychology or try to impose our 2022 conceptualizations on primitive or ancient humans, but perhaps gender wasn't relevant in that kind of sense.
Yeah. And you wonder what a society would look like if they didn't have gender. And I wish I knew more about like Two-Spirit as a gender identity and how that fits into those Native American societies and social groups, right? And it seems like that's sort of an expression of this spectrum. There's people who fulfill both gender roles or identify with both gender roles to different, varying degrees. And I think that the existence of those independently in other, societies highlights the fact that there probably is this underlying, fact about humans that some of that really gender identity exists on a spectrum, and these buckets that we put, male, female, are really arbitrary, and again based on like statistical norms.
Yeah, so if that's the case, we spoke to student Dr. Ben a few months ago about our very loose, very weak, if I can call it that, our societal understanding of the biological underpinnings of gender. I know that there's no real answer to this question, but from your understanding and speaking very broadly, is there any medical consensus or reason for these different forms of gender expression?
So, I mean, I think a conversation like this would be incomplete without discussing the difference between sex and gender.
Sure.
And I think that, biological sex is something that we would probably agree is air quotes real, relating to genetics, genitalia, hormones, however you want to traditionally measure it in a scientific sense. And those different metrics may not always align with each other. And that being very distinct from gender. And again, if we look at the DSM, what they define as gender is the public lived role as a boy or girl, man or woman. They specifically use that binary. And considers the contribution of biological, psychological, and social factors. And so they're acknowledging that there's this confluence of multiple factors, some of which are internal, biological, and psychological, and then the interaction with the social element. And so I think that you could point to some genetically based characteristics as a trend, but I think it's one of those things where, it's not like there's a single gene that codes for gender. It's like, scales, if you can imagine weights on scales, and the precise balance is a contribution of like hundreds or thousands or more genes probably that contribute different things like hormones and, development of reproductive organs and the way your brain is developed in utero and all these things, and your exposure to the environment. So, I mean, I think there's definitely a biological component. I think there's definitely an interaction with your environment, both social and like physical environment, that affects your gender. And I think that for the majority of people, they find themselves fitting comfortably into one gender just because that's where the weight of those interactions, those all of those factors place them. But that's certainly not the case for everyone, and that's why we get this spectrum.
I love that we are diving into these unanswerable questions. I love exploring sort of the philosophy of gender while having these like very practical and medical underpinnings. The idea that my evangelical, bigoted dad could potentially stumble across this video and be absolutely perplexed by everything that we've been discussing here. Just fascinates me and excites me. But ultimately, I guess I'm curious what sorts of changes you feel are appropriate or necessary even for the way that the medical establishment understands gender or treats or offers care to people who are gender diverse.
So I think the biggest problem with the medical model as it stands today is this problem of like gatekeeping and the fact that and I think this is where a lot of our perceived perhaps disagreement comes from, is the fact that in order for something to be considered extant in a medical model, it has to classify itself as a disease, which means checking some boxes, right? So I think there are problems with gatekeeping where we say, well, if you want to get hormone therapy, then you have to go and have a psychiatric assessment, and that can be very traumatic in itself and very invasive, certainly. And there are problems with that because it prevents people from accessing care. And I think physicians and psychiatrists have psychiatrists are physicians, I should be clear.
Sure.
They have the best interests of patients in general at heart because they want to make sure that, a person fits into this category because they know that's how they know that this treatment is going to work. Right. But we also have to recognize that presents a barrier to getting people the care that they need. Right. If they never present to your office because they're afraid to undergo that invasive discussion, then you're not going to be able to help them. And so we're failing this invisible population of patients who never present because of the barriers that we put up. And so I think that's a design problem with the way that our medical system works. I think that the barrier is coming from the right place. And I think that the barrier is, that need to assess a patient in order to make sure that we're doing the right thing is still necessary. I don't think that we need to be opening a place where people can just walk in and say, give me hormones. I don't want to hear any other questions. I don't think that's the right way to go.
Sure.
But I think that some form of assessment is necessary, and it needs to be less intimidating and more accessible than it is now.
And it's very tricky. I've actually, I'll admit, rationally or irrationally, I've lost a little bit of sleep after recommending on this show a specific app that is pretty comparable to Roman, if folks are familiar with that. Roman is a way of receiving erectile dysfunction meds, as well as like a small handful of other things, more or less anonymously online. Theoretically, there is a interaction or a prescribing physician that is like signing off on all of this, but it's done in the least gatekeepingest way imaginable. And I only reference Roman because there is a very similar program that's called Mariposa that offers hormone replacement therapies online. And I have very mixed feelings about it because the reality is I work with a number of transgender folks that for very, very valid reasons have complex trauma related to the medical establishment, and they need medical care. And I cannot stress, I don't think this is shocking to you, MD, but I cannot stress to the audience enough how much very real fear there is in the transgender community with regards to the medical establishment. I certainly don't speak for that community, and I don't want to oversimplify things or paint with too broad a brush, but it's near universal, the distress that has been caused by interactions with the medical establishment. And I understand where that is coming from, and I don't love the opposite version where it's just buy whatever you want carelessly and casually. But this is a very complex issue.
Yeah, totally. And I mean, the flip side is that no treatment is benign, period. Right?
Sure.
Like every treatment has side effects, including hormone therapy. but even to a greater extent, surgical treatments have a side effect profile that can be, potentially damaging to health. So, I mean, the very fact that, it's sort of a shame that the interventions that are required, the medical treatment that's required for some of these patients is potentially dangerous. And it requires, I think, if we're being responsible, interactions with a healthcare system that has lost the trust of the community. And it's something that we need to be working towards gaining back. But I think there's just no safe way to deliver that care without having this interaction in some form.
Sure. Well, outside of medicine, this is again another very big question. But what is it that you personally worry about with regards to the way our society understands these issues? What do you think that the average Joe maybe misunderstands about the biological or the medical aspects of gender?
Yeah, I think going back to the caller that we had on Truth Wanted is perhaps a good way to address this. So James, I think a lot of people who are opposed to transgender initiatives in their various forms see it the same way that he does, in that trans people are making a statement of fact about their gender, and people perceive it as relating back to some physical thing that is real and provable and scientifically examinable. And I don't think that gender is. I don't think that we could ever, with our most intense brain scans, look at a brain and tell, yes, this person identifies as a male or female or whatever, right? We can tell things about biological sex, but I don't think that there's anything fundamental about anyone that can tell you their gender. And I think that that's the real misunderstanding that the average person has, is they think that trans people are stating something that is objectively verifiable about themselves. And they're saying that, and in those people, the average person's mind, it's coming into conflict, right? So they're saying, no, you have a penis, and therefore that's a scientific fact. And therefore the scientific fact that follows is that you must be a male. And
you can't identify as a dog or as a attack helicopter. And we start to get these old arguments.
Right, exactly. And so I think that what would be most useful for the average person is to try to understand gender in a less scientifically defined way, and a less, air quotes, real way, as in something that you can examine externally, and think of it more as like sort of what I was alluding to earlier, as like someone's name. It's something that they identify as, and it means something to them, and it may not mean something to you, but that doesn't really affect how you should interact with them. And like, it would seem absurd to discriminate against people because their name started with a G or their name started with a W or something, right? And so I think if we start to view people's expression of gender as a form of self-description, rather than a declaration of a scientific fact, then people would be a little bit, we get a little closer to understanding that maybe they're not saying the same thing that you think they're saying. And I would hope that brings a little bit more understanding and patience to the average person. Does that make sense?
No, absolutely. I mean, I couldn't agree more. And I guess the only thing I might highlight is there could be some portion of the audience that heard you talk about, being less scientific, and might kind of get their hackles up over that idea. And I'll just say, in the social sciences, we love to swim in these waters. We're very used to the idea of things being made up and real at the same time. I've used this example on the show before, but by that metric, the United States of America is not real. It's a social construct, right? It's just an idea that we've all agreed on. The idea that money exists, that like little pieces of paper have value, is just a social construct. It's a contract that we all agree to. And our gender is very real and very meaningful in a scientific sense. But that doesn't necessarily mean, at least in this day and age, that we can point to it on a like some sort of spectrograph or some sort of MRI or anything else.
Or look at it under a microscope and identify it, right?
Yeah.
Yeah, I totally agree. And that's an interesting, you should come on Truth Wanted with me sometime, Christy, and we can talk about whether or not holes exist.
Oh, man. Fucking, yeah. All right, let's do it. Let's do that. But before we wrap up here tonight, I guess I just wanted to ask if there were any particular organizations or political activism opportunities, any further reading or resources, or really anything on these subject matters that you might want to point people towards.
I think so. Like I said, I'm not an expert in this. I think that the best thing you can do is try to get informed and get informed in the best way that you can. And that, I think, means looking up some of the literature that's been published. And there is going to be literature for whatever your level of education and knowledge about the area is. And you can always get in. And if you just do a Google search, looking at a reputable, from some reputable agencies, then you'll find something that's at your level, and you can start there and just go wild, right? And so always getting more informed is where I would recommend. And unfortunately, I don't have any great organizations to plug, but I'm sure you do.
Sure. Well, yeah, if the goal here is just to become a little bit more aware, a little bit more informed of these issues, I have always enjoyed pointing people towards the book How to Understand Your Gender by John Ifanetti and Meg John Barker. It's a very simple, very easy read that exhaustively explores these topics, and definitely worth people's time. But I'm also very much of the opinion that these conversations are sort of ongoing. Like culturally and socially, we are still figuring this shit out. As I pointed out, the American Psychological Association and the World Health Organization are kind of rapidly changing their understanding of these things as well. And so I definitely think there's value in keeping your finger on the pulse. Nobody expects you to know every detail of what is the like esoteric understanding of gender in the social and medical sciences and these types of things, but be engaged in the conversation. And for that reason, I am just so grateful to everybody who has stuck it out for this like very complex and maybe somewhat esoteric conversation. I know I've had a great time, and I super appreciate you being here. And this has just been really everything that I want to do on my Thursday night. So thank you so much for walking us through these ideas.
Oh, yeah, it's been great for me too.
Yeah. Well, with that, I want to take a moment and remind people of all the other great shows that exist on the Atheist Experience Network. You can find an audio-only version at tiny. Clearly, this is a conversation that has a lot of underpinnings and a lot more to learn. So I would encourage you to jump into that conversation, to be reading, to be looking to understand. And one of the best places that you can do that, to my mind, is in the Secular Sexuality fan group that you can find on Facebook. That's going to be at tiny.cc/FBSSG. Similarly, there is always a great conversation about gender, about atheism, about Christian nationalism, and how it impacts all of these discussions going on in the atheist community of Discord. And you can find that at tiny.cc/ACD-Discord. And then most importantly, I've previewed this a couple of times, but we are live. It has launched. It is happening. We have great new merch and some really exciting opportunities at tiny.cc/merchaca, where we have all kinds of new products, including, for the first time ever, some dumb shit that I happened to say in the heat of the moment on the back of a t-shirt, which is really the only reason I ever wanted to get into activism in the first place. I feel like I've achieved it. Maybe this will be my last show. We'll see if I show up next week. But with that, I want to really sincerely thank all of the incredible people that are designing these t-shirts, that are making these shows happen, that are moderating the chats, that are making it possible for folks like MD and I to sit here and contemplate our navels and explore the philosophy of these things. They're not just the folks that you see on this crew cam, although I am incredibly grateful to all of the hardworking people that help to make this show happen. I sincerely, to the audience, I cannot express to you the number of hours and the amount of dumb conversations about music and about gender and about atheism and every other good thing that happens between these wonderful folks. With all of that, MD, I guess I just wanted to ask if there were any final thoughts that you'd like to leave with the audience about these like very heady and kind of complex issues.
I think that my recommendation is always that you think carefully about these things and then try to prove yourself wrong and try to examine your ideas from the standpoint of someone who would disagree with you, and revise your opinions as you make new discoveries and as you learn more. Always be willing to change your mind.
Always be willing to change your mind. Great notion to leave it on. So I suppose with that, I'm going to encourage everybody listening. Well, before we walk out the door, I guess I just want to take a quick moment and acknowledge once again that MD and I are both cisgender folks doing our very best to read about, to understand, and to express these ideas, while also wanting to acknowledge that as much as we love and want to support the transgender community, that we are only tangentially connected to it. And nothing that we have said here should be seen as correct or as comprehensive. But we hope that this conversation has helped to illuminate some of the complexities here, while also wanting to make space for the fact that this is kind of cutting or even bleeding edge social and philosophical science, if I can use that term, and that we would be honestly, sincerely proud and excited to be corrected. So if there is anything that you take issue with, anything that you would like to add, I really hope that you'll keep the conversation going. Clearly, you can give us a call on the show. You can certainly send us emails, but we really, really do adore your feedback. Disagreement or otherwise, negative feedback is especially useful. So please let us know what you think about this conversation. Thank you for being a part of our community and for participating in the meaningful work of building a better society for all genders. And now that you've done a little bit of homework, now that you've done your research, now that you've joined us in some of this like emotional and mental labor, you might have earned yourself a nice break. So grab yourself a medical textbook, find your favorite model, whatever that means to you, or perhaps your favorite French film, and give yourself a big old orgasm. Or better yet, give somebody else one.
Watch Talk Heathen live Sundays at 1 p.m. Central. Visit tiny.cc/YTTH and call into the show at 512-991-9242 or connect to the show online at tiny.cc/callth.